no typos stand out there.
You've all heard about the CDH study group, big fans we are. Collection of 85 hospitals, 52 active centers. 52 active centers working together on CDH research. And Pam and Kevin Rowley headed up. They do all the work, Pam the database guru, and we're so happy that they're here and they can speak to us. And I apologize I introduced both of you.
And of course, a
But
lot
we're
of
so
people,
grateful that you're here.
business-wise, try to.
Great, thanks, Don. Good morning. I'm Kevin Lau. I'm a pediatric surgeon by training and still practice in Houston. When Don asked me to talk, I figured I'd give you all a history of where we've come and where we are today with management diaphragmatic hernia and segue into how that got us started on both the CDH registry and study groups. As many of you know, it's a relatively, in the scheme of birth defects, relatively common, but the current mortality rate is around 30%. If you do the math, it actually accounts for about 1% of total U.S. infant mortality. This is data from a paper that was published from San Francisco based on 1995, I updated it to around 2000. And what they looked at was the cost per both survivors, non-survivors, and ECMO-treated patients. And if you then did the math times the number of survivors at the time, we would be talking about $600 to $700 million of hospital-based care for diaphragmatic hernia. That's not a lot of patients. And a definable percentage of total healthcare expenditures, and it doesn't include any of the long-term follow-up costs. So one of the reasons we're interested in it is obviously uncommon, but it still has a high mortality, and it's a very expensive problem to deal with from a medical health care standpoint. As many of you know, about 80% are left, 20% right, and there's a small percentage that are bilateral. The hernia, you may have heard the term, it's called a Bachelek hernia. Bachelek was a pathologist, and he in the mid-1800s, described two patients, postmortems, with defects in the diaphragm. One of these is a really large defect, this is a newborn, and the other was a few days older. He wrote these up and he published it in a European pathology journal. As we became more capable of having survivors, it became known as a Bachelek hernia because he's the pathologist who described it. So these are current statistics. So in 2009, when we looked at registry data, overall survival for all comers is 69%. As I'll talk about, that's a dramatic improvement in the last 30 years. However, we still have the 31%, and there's some issues that many of you are personally aware of with the 69% survivors. So if we start talking about when it's really meaningful to talk about diaphragmatic hernia, it's really not until the 1950s. Patients did survive before then, but there were very few, and most of them were older patients who were diagnosed late. Anesthesia was really not that great, and it wasn't until the 1950s when we first started having neonatal repair, and there were few survivors. But if you took the 1950, and this is a typical patient with a diaphragmatic hernia, with bowel loops in the left chest, heart shifted over, there's a very classic x-ray for a diaphragmatic hernia. But in 1950, if we would have the patient that'd be 18 hours old or older, the newborn with immediate distress in 1950 died. So that patient wouldn't have been on this x-ray. The problem is that the heart shifted over and the baby has respiratory distress. And that's the clinical problem that people were dealing with and still are. But the real problem in 1950 was we had no ability to do general anesthesia in infants. We had no intensive care units for infants. The first ICUs in infants were developed at Children's Hospital in Philadelphia, and they were surgical intensive care units. There were no ventilators. Mechanical ventilation didn't come on board, as I talked about, until the 60s. No intratracheal tubes, and really no widespread availability of surgeons. So the solution was to delay, because you had people who just couldn't manage these babies, and the best idea was let's just wait, and hopefully the baby will get older, and of course they didn't, and they died. And then if you then looked at the early 1950s, this is Robert Gross, and Gross is was a pediatric surgeon at Children's Hospital in Boston. And as we play out how diaphragmatic hernia managed, generations. He was responsible for ultimately training through different generations, 80 to 85% of practicing pediatric surgeons. That played an important role in how we managed those babies through the late 1980s, early 90s. Gross described the first repair of an infant under 24 hours of age. Prior to his description, no baby had ever been operated on before 24 hours of age. And what this prompted Dr. Ladd and Gross, the policy of waiting until a child is older and stronger is responsible for the loss of a great many lives. So they felt that you just needed to go ahead and operate on the newborn with diaphragmatic hernia, and then if you delayed surgery, you were going to lead to death. And in point of fact, that's occurred. That was how things did play out. Different patients though. We had some more neonatal survivors in the 1950s. A few people started doing that. And there were scattered reports in the 50s and early 1960s, but the main focus of these scattered reports was to demonstrate you could actually operate on sick newborns, and it highlighted the lethality or the problems with diaphragmatic hernia. And it led to and there were reported statistics anywhere from 30 to 60% survival, but this led to this pervasive myth that we were unable to impact mortality in diaphragmatic hernia. And what had occurred over time, as I'll show you, is our patient population was shifting over time. And while mortality stayed the same, the kids got sicker and sicker. By the end of the 50s, early patients who were in immediate distress did not make it to transfer to any hospital to care for them. We didn't have neonatal transport. We didn't have the ability to intubate an infant. So if you had an infant born in an outlying hospital, it didn't survive. In order to get into the literature, you have to be in a hospital where they're going to describe you. And if you didn't get into the children's hospital, you didn't get into the literature. So these patients would die. Hence, there was a lot of these very high-risk patients that never made it into the hospital. Early operation was really not widespread, and there was really minimal ability at all to do mechanical ventilation. It wasn't until the 60s that we had to, and in fact it was in the Vietnam War that they developed a pressure-regulated ventilator. And we needed that ventilator because the only way you could hook it up in the aircraft was to hook it up to the pressure line in the aircraft. So they had pressure-limited ventilators, regulated ventilators, it was the bird ventilator, and from that they created the baby bird ventilator, which was really the first ventilator devised for neonatal mechanical ventilation. Mid-1960s. Anesthesia began to improve, and we started to have neonatal intensive care units. So that conglomeration, then we could start taking care of sicker babies with respiratory failure. If you, however, Dr. Schneider was the chief of pediatric surgery in the 50s and 60s. I trained in LA, and I found some of his slides, and this is one of his slides. And he talked about respiratory diaphragmatic hernia, but the report was talking about infants with symptoms over 3 days of age. And as I'll talk about more, these patients, those kids who present actually over 12 hours of age, certainly over 24, are really not the kids we're talking about at all. Survival in that cohort of patients is basically 100%. If you looked at the distribution of the same paper, he had 31% of their left-sided hernias were doctored with over 3 days of age, and only 40% were under 72 hours, and basically none of them prevented in the first 6 hours of life. So by the 60s, some of the early distressed patients made it to transfer. Early operation was more prevalent, early being in the neonatal period because people were now doing neonatal surgery. It increasingly was viewed as an emergency operation. Mechanical ventilation was arrival, but survival was still around 50%, though as I say, patients were sicker. They're getting sicker and sicker babies coming into the hospital. If you move to the next generation in the 70s, now you could do arterial blood